ओके ओके।
I'll start with the PPT.
नहीं मैम,
Wait.
थोड़ा वेट कर लीजिए, एक दो मिनट थोड़ा सा मतलब कि डिले आता है।
In the sense, when the live stream is going on, it will update 2 minutes late or something like that. It will not get up as of what you stream.
Okay. So I'm asking, should I do the same thing tomorrow? That is on the day.
In the live stream, in the sense for YouTube live session, what happens is we'll be meeting 30 minutes prior to the actual session, and
Acha, okay.
we will be having the communications via your WhatsApp and via your phone. Phone should be kept in the vibration mode actually,
Okay,
not in
fine.
the ring. And one more thing is you should have an eye on the WhatsApp so that if it goes wrong, I will be communicating via WhatsApp, and you need to adjust it on immediate basis. And Sagar will be having the entire control in the backend access.
Okay, fine. Cool.
Okay.
That's okay.
So, shall we start, Sagar?
या सर, वी कैन स्टार्ट।
Yeah, you can proceed ahead. Proceed.
एक्चुअली क्या है ना मैम, मैं आपको एक चीज और बता दूं कि अभी जो मैंने आपको प्रोवाइड किया है ना, मतलब
हाँ.
कि सारा कुछ डिटेल्स वगैरह वो सारा कुछ सेम रहेगा। बस जिस दिन आपका लाइव सेशन होने वाला है उस दिन बस वो जो स्ट्रीम की है ना वो खाली चेंज हो जाएगा, मतलब कि उस टाइम मैं आपको एक एक्स्ट्रा की दे दूंगा। ठीक है,
समझ गए, नो इश्यूज।
हाँ, तो अब आप कंटिन्यू कर सकते हैं।
Okay. Good evening, students. We shall begin with internal medicine session on top 25 clinically important questions. Moving forward to our first question today, a 45-year-old patient was brought to the emergency with complaints of breathlessness. On examination, the JVP was raised and fails to fall during inspiration. What is not likely the cause of his breathlessness? Keep in mind, the key point here is they're asking what is not likely. So the first option is right ventricular infarction, option B constrictive pericarditis, option C cardiac tamponade, or option D restrictive cardiomyopathy. So if anybody knows the answer, could you please put it in the chat box? Okay. So the answer here is cardiac tamponade. Now, why is this cardiac tamponade specifically? So first thing is, what is this question about? It is about Kussmaul sign. Okay. So Kussmaul sign is defined by either a rise or a lack of fall. So this is the point to be noted, that it is lack of fall of the JVP with inspiration, and it is classically associated with constrictive pericarditis. But although it has been noted in several other conditions, which include restrictive cardiomyopathy, RVMI, massive PE, severe pulmonary hypertension, right heart failure. Out of this, what you have to specifically remember is the SVC obstruction, which was asked in the previous AIMS 2019. Okay, so you have to be very careful about this question. So amongst the JVP, also previously asked questions include, where do you see absent A waves? You see it in atrial fibrillation. Large A waves in pulmonary hypertension and pulmonary stenosis. Look for Cannon A waves. Okay, this is a very frequently repeated question. Cannon A waves are seen in complete heart block, ventricular arrhythmias, or ectopics. Large V waves, also known as CV waves, are seen in tricuspid regurgitation. Rise in JVP, which we previously discussed, Kussmaul sign, is seen in constrictive pericarditis. So among these, there is no option of cardiac tamponade. Correct? So that is why the answer to the previous question is cardiac tamponade. Moving on to the second question. 60-year-old chronic smoker presenting with breathlessness and palpitation. Comment regarding the chest X-ray and ECG findings. Okay. Students, you have to pay attention here that two systems as well as two different subjects have been integrated in medicine. You also need to know radiology along with medicine. So you need to know what is this radiograph of a 60-year-old representing. Okay, the clues what we have in the question is he's a smoker, a chronic smoker. So this is a chronic disease. Okay, a chronic disease in a smoker is, this is your first clue. Second clue is the ECG that you're seeing here. What you have to identify is whether this ECG is a bradyarrhythmia or a tachyarrhythmia. So you have to calculate the rate. See, grossly you can see that it is a tachyarrhythmia, correct? The heart rate is more than 100. Okay. So amongst the tachyarrhythmias, first and foremost step is to see whether this is a wide QRS or a narrow QRS. So QRS normal duration is how much? It is up till 120 milliseconds. This is the normal duration of a QRS complex. So more than 120 is known as wide and less than 120 is known as narrow. Okay. So what are the options given? Let's go to it and let's try to rule it out. Okay. The first one is A, bronchiectasis and the ECG showing atrial fibrillation. Second one is emphysema and the ECG showing MAT, that is multifocal atrial tachycardia. Third option is emphysema with the ECG showing atrial flutter. And the last option is pneumonia and the ECG showing SVT. So come back to this radiograph and see what you can interpret from this radiograph. First thing you can see is that there are a number of ribs that are not normally seen in an inspiratory film. That is, you can count from up 1, 2, 3, 4, 5, 6, 7, 8. So normally you can only see up to 4 to 6 ribs. Here you can see more than 6, that is almost 8 ribs you can see. So this indicates that the lung is hyperinflated, correct? Also notice that the domes of the diaphragm are almost flat, correct? Plus the space between the ribs is increased. Okay. There is also a subtle sign, this is a bouncer which is also asked in radiology. This sign is known as the saber-teeth trachea. So this means there is a narrowing of the intrathoracic trachea. So all these features point towards what? Can anyone tell me in the chat box? It means that there is emphysematous changes in the lung. Okay. So now we have narrowed it down to 2 options. Correct? So the 2 options are B and C. So now they are testing whether you know your ECG well or not. So how do you approach a tachyarrhythmia? So once you're done with diagnosing it to be a tachyarrhythmia, you have narrowed it to be a narrow QRS tachyarrhythmia. Now next step is to determine whether it is regular or irregular. In our ECG, it is irregular. Okay. You have 2 options in irregular narrow QRS tachyarrhythmia. Either it's an atrial fibrillation or a MAT, correct? What is the difference between atrial fibrillation and MAT? Atrial fibrillation has absent P waves. And what about MAT? MAT has more than 3 types of P. Okay? So that's what you have to remember. More than 3 types of P waves. Please make a note of this question because this has appeared in your INI SS 2020. Okay? So your multifocal atrial tachycardia seems to be the answer in this question. Okay? So let's review the ECG. You can see it's a tachyarrhythmia with a QRS less than 120 milliseconds, which is irregular, and there are 3 types of P wave. See, you can see here, there is a single type here. There is a different type here, correct? And can you see there are different types of P wave within the same lead, correct? So this means this is a multifocal atrial tachycardia. So the learning point is always take home a message that in COPD, MAT is extremely common. In emphysematous patients presenting with tachyarrhythmia, Math should be the first differential diagnosis. Alright, so let's move on. Quickly tell me, this is a little difficult side of a question. A 24-year-old patient presents with acute STMI. So this itself is a bouncer. 24-year-old patient, correct? Very young. Is presenting with MI. On detailed evaluation, he was diagnosed of a very serious disease called pseudoxanthoma elasticum. Which of the following is not a feature of this syndrome? So you must be aware of such questions also, which seem difficult, but all they're asking you is to tell you the features of this particular syndrome. Okay? And they're asking you which is not a feature. So you should know the features of this syndrome. So first is premature atherosclerosis. Second is angioid streaks on fundoscopy. Third, palmar xanthomas. And last is cobblestone appearance of skin. Correct? So in this is a straightforward factual based question which has been presented as a case scenario here. Okay. So in this, the right answer is palmar xanthomas. So now tell me, where is palmar xanthomas? Palmar xanthomas are pathognomic of one more MCQ favorite, type 3 hyperlipoproteinemias. Type 3 hyperlipoproteinemias. Okay. So in CVS, you have to remember pseudoxanthoma elasticum. This is one of the syndromes which presents with premature atherosclerosis causing ST elevation in the young. Correct? Okay. So moving on to our next question. A 55-year-old hypertensive presented with complaints of right-sided hemiplegia with aphasia past 3 hours. On examination, the patient was afebrile. BP was 170 by 100, RBS was 172, VCS was 10 by 15. Read the question carefully. They're asking you what is the next best step. Okay. So don't get confused. Think properly. If this patient had come to your emergency, what would you first? Okay. Option A, would you make a presumptive diagnosis of acute ischemic stroke and go ahead with IV thrombolysis? Okay. Second is reduce the BP with IV antihypertensives. 3 is treat hyperglycemia. And last option, do NCCT to rule out intracranial hemorrhage. Okay. So firstly, I want to ask you, what happens when can you thrombolyze the patient? IV thrombolysis is allowed. IV thrombolysis is allowed within 6 hours. Okay. So as soon as the patient comes into your emergency, would you just go ahead because he's come within 3 hours? Would you go ahead and thrombolyze him? No. Why? What are you scared of? First, you need to stabilize the patient. Do your circulation airway breathing. Assess his BP. Okay. So when do you have to reduce your BP? Do you have to reduce your BP in this patient? No. Why? Because the BP cutoff is more than 185 by 110. Okay. Do you reduce his RBS? The RBS cutoff again is more than 180 or less than 60 is when you treat hyper or hypoglycemia. Would you treat his fever? No. Why? Because he's febrile. Okay. Suppose he has fever, you're supposed to treat or bring down the hyperthermia or the pyrexia because it has adverse effects if you thrombolyze a febrile patient. So once you have stabilized the patient, next you do an NCCT. Why an NCCT? Because it is quick, it is cost effective. Okay. And we do not do this to diagnose an ischemic stroke, but we do this to rule out hemorrhage. Because if there is intracranial hemorrhage, it becomes a contraindication to your IV thrombolysis. Okay. So the steps of stroke has been time and again asked in your MCQs. I need you to be thorough with these steps. Okay. Okay. So going to our next question. A patient presents to emergency with vertigo, numbness of ipsilateral face and contralateral limbs, hoarseness, dysphagia, ipsilateral Horner syndrome. Identify the artery occluded. Now, this question seems to be very difficult at the first glance, correct? Because you have so many things going on in this patient, you don't know where to approach from, correct? And you have directly been asked to localize the artery. What you have to do in this case, your best bet is to rule out as many options as possible. How do you rule out such cases? You need to see that the ipsilateral face and contralateral limbs are involved. So what is this known as? This is known as crossed hemiplegia. Okay. Or hemisensory loss. Okay. Here specifically it's hemisensory loss because it is numbness. So anything that is crossed, what does it indicate? It indicates brain stem involvement. Correct? So because it is brain stem involvement, directly you can rule out your posterior cerebral artery. So you have ruled out your posterior cerebral artery. What remains is your superior cerebral basilar and your posterior inferior cerebellar artery. Now next thing what you have to identify is, you have to identify what are the cranial nerves that are involved. Hoarseness, dysphagia, and very importantly, ipsilateral Horner syndrome. So Horner syndrome, dysphagia, hoarseness, all occurring. This is because of your lower cranial nerves like cranial nerve 9th and 10th. Okay. Your ipsilateral Horners means it is sympathetic chain. This is your biggest clue. So the moment you hear sympathetic chain, where is the sympathetic chain close to? It is close to your medulla. Okay, it runs through your lateral aspect of your medulla. So now this is the integration of your anatomy. So your medulla is supplied by V4 and branches of V4. V4 is fourth part of vertebral artery. So the branch of V4 is your pica, posterior inferior cerebellar artery. I know this is very difficult, but you have to try and localize because this again has been asked in your INI essays. Okay. All right. So with this, we move on to our next question. A 72-year-old male is brought to the hospital with confusion, drowsiness. His son says that he has been urinating more frequently than normal, eating very little over the past 7 days. Capillary blood glucose is 800. Which of the following would not be seen in this patient? Okay. Now again, this seems a little difficult, but read it again, very, very easy. See, there are only two emergencies, okay? There are only two emergencies with high glucose, okay? High GRPS. So what are the two emergencies? One is DK, the other is HHS. That is what. So it narrows it down to two differential diagnoses, correct? So the moment you hear 800, you're automatically, biased towards HHS. Why? Because less than 600 or more frequently less than even 400 is seen in DK. In HHS, it is seen between 600 and 1000. Okay. So this goes more towards HHS because it is at 800. Also, what you can see is It is a 72-year-old male with confusion and drowsiness. Okay. So hyperosmolar hyperglycemic state, presence in elderly with altered sensorium. So what is not seen? Okay. Which of the following would not be seen? That is the question. Will it have a normal pH? Yes. Will it have pre-renal azotemia? Yes. Why? Because there is depletion of intravascular volume. Okay. So that is why you have pre-renal azotemia. And the serum osmolality is 370. Okay. Normally in HHS it will be more than 350. So this also fits into the criteria of HHS. So what is not seen? Kussmaul's breathing. Now, don't get confused between Kussmaul's sign and Kussmaul breathing. Kussmaul's sign was seen in JVP. What is Kussmaul's breathing? This is seen in metabolic acidosis as a compensatory breathing. Okay, compensatory hyperventilation. Okay, this is seen in DKA. Okay, so this is how you need to gradually break down an even lengthy question. Okay, so next we move on to a 75-year-old male presents to OPD with high-grade fever, productive cough. On examination, his RR was, his respiratory rate was 35, his heart rate is 105, his BP is 90/60. How will you manage this patient? Okay, admit in what? Treat with levofloxacin doxycycline. Option B, treat him on outpatient basis with azithromycin and ceftriaxone. Admit in ward and treat with levofloxacin, or admit to ICU and treat with azithromycin and ceftriaxone. What would you prefer? Okay. Now, how do we approach? See, they're asking you where to admit, where, and what to give. What to give. Okay. First, we'll check where to admit him. How do we decide where to admit him? This is based on something known as CURB 65. This is curb 65. What does C stand for? Confusion. Okay. What does U stand for? Your blood urea nitrogen bun more than 7 millimoles. Correct. What does R stands for? Respiratory rate more than 30. And B stands for systolic BP less than 90 and diastolic less than 60. 65 is the age cutoff. Okay. So you can see here his RR is high, his age is high, and his BP is also 90/60. So this makes it 3 points. Okay. So the moment it is 3 points, okay, 0, you can treat it on OPD basis. 1 to 2, you have to put him in the ward. Okay. And if it's 3 or more than 3, then you have to take it in the ICU. Correct? So this patient fits into the criteria of an ICU admission. Automatically, the answer becomes D. But we also should know that it might not always be this easy to come down to the answer, narrow it down. You should also know what is the treatment we give for community acquired pneumonia. So what is the treatment for CAP? The first line treatment for CAP, of course, on an OPD basis can be a simple azithromycin. But since this is an ICU treatment, it is azithromycin plus ceftriaxone. We generally avoid giving fluoroquinolones as the first line of treatment. Okay, so you should always know that give azithromycin and third generation cephalosporin for an inpatient community acquired pneumonia. Okay, so we go on to the next question. A 82-year-old female with history of moderate aortic stenosis presented with fatigue, weight loss, night sweats for last 14 days. Blood test results are updated below. Okay. Echocardiography revealed an intracardiac mass on mitral valve. Blood cultures revealed Streptococcus galeolyticus. What additional investigation should be performed? CRP is 187, WBC is 16. So, what else? Should you perform a cystoscopy, a colonoscopy, a bronchoscopy, or a hysteroscopy? Okay. So, first thing is you should identify what is the patient suffering from. Okay. What is the patient suffering from? The patient is suffering from something known as infective endocarditis. Okay. In infective endocarditis, there are vegetations present on the valves. These vegetations are bacteria along with WBCs and fibrin. Okay. So now we need to understand generally a sterile environment in the heart. How does it get? Hello?
The valves. These vegetations are bacteria along with WBCs and fibrin. Okay. So now we need to understand generally a sterile environment in the heart. How does it get there? Hello?
Yes, Sagar, are you there? Sagar, am I audible?
Hello. Yeah, sir. Yeah,
So, doctor, there is no issue with your network, I feel.
yeah.
Okay.
If you are going ahead with taking class by here only. And
Thank you.
one more is what I felt now there is something issue with the distribution of how you use the pen tab on the screen.
Yeah. The thing is, no, for the last two questions, I'm still to make some images to put, because the moment I start writing, I'm taking a lot of time. Like you can see, I've just finished 6 questions. So I need to put
Yeah.
6 more within 1 hour. So it's getting time crunches there. That's why I'm putting more and more tables and images.
No. That is not an issue. The issue is like while you are using the pen tab, na, the what it is
Hmm.
what I'm seeing is like where you are writing somewhere on your face itself.
Acha, okay, fine. I'll keep that in mind. I'll
Yeah,
keep that in
like
mind.
what happens while we are seeing in the front end, it something looks odd.
Okay,
Like
fine.
where you are using it should be restricted to some areas. Like when you write on yourself, like you are writing something on your face itself, actually.
Arthaitu. So I have to avoid the right bottom corner.
Yeah.
Okay,
Right
fine.
bottom corner, or better you. Sagar, is there any solution? Where he went? Sagar, are you there?
Yeah, sir.
Like what I seen, like she's
Mhm.
using the pen tab or she's writing on her face itself, actually.
Okay. So yeah,
So
ma'am. Particularly, you don't use that much area. I will mark it. Okay.
अच्छा ठीक है ठीक है
हाँ
ठीक
हाँ,
है
मैं उसको ना मार्क कर दूंगा।
ठीक है कोई बात नहीं तो मैं
कैसे करना है
तो
वो
ना
बता
मैं
देंगे एक
इस
बार
तरफ
आप।
तक ही
एक बार
रखती हूँ है ना
हाँ हाँ, बिल्कुल।
है ना ठीक है
हम्म।
और कुछ
नहीं मैम, बाकी सब तो ठीक था। फिर जो भी मतलब टेक्निकल एस्पेक्ट्स है टीचिंग से रिलेटेड, वो तो सर ही बता पाएंगे।
ठीक
okay, and related to teaching, the something what I wanted to say is like, do you want to add those descriptive which I have given, or you will be continuing on yourself?
no
What
I'm
do you think?
adding those but I don't want it to be only text I hope you understand that because no if it's only text no I don't think the kids are going to be patient enough to read it
Yeah. Kids will not be patient. I
huh.
knew that very well.
Yeah, so
So
that's why I'm adding something like a table or something they can take a screenshot and later probably write it down.
no, that the thing I need what I need something like before you update the PPT to team, you
Huh?
better update those things and you update.
Yeah. I'll tell you the total, whatever is going to be presented that day only, I'm going to give it to you.
Yeah, you'll be updating by tomorrow morning or when you are going to update it.
I'm going to sit today night and work at it. So I'll give it to you by tomorrow morning. Yeah.
Yeah, anything is fine, not an issue.
Okay.
And the thing is, like, I can understand that while I was preparing, I have did those things, and the thing is, I have prepared in that manner itself. That is not an issue. But the thing is, nowadays they are sticking on to something called what you call more and more flowchart, more and more tabular
Huh.
columns,
Huh.
etc. I knew that very well.
Hmm.
And even for some of the things of microbiology related to infective endocarditis, I feel that I was supposed to give it in a tabular column. Actually, it is a standard tabular column which you are supposed to follow, but I have entered it on a direct fashion.
Yeah.
Yeah,
So that's what whatever this is, we don't want to give out too much also, na? Because this is supposed to be like a revision top 25, questions. So I'm
no,
not going to
actually,
go in depth.
like what the points that was added, na, like what I
Hmm.
felt is some of the points related to infective endocarditis, or some of the points related to hypokalemia or something like that, related to ECGs and all, like
Hmm.
the
Hmm.
important points that needs to be explained, like we are supposed to highlight what is our quality in the upcoming product.
Okay.
Like
Okay. Okay.
we need to keep something in the mind, right? Like what we are going to do with this, like whether we are well settled in the market or we are supposed to be well settled in the market. So that
Understood.
while
Understood. So,
explaining these things, it should be like I can understand that when the time restrictions are given, we can't explain each and everything in the fashion which we do on regular basis. Like
okay.
for the first question, as I've seen, first question what I have given, that is something related to what I have given. I have forgotten right now. That is something, if I'm not wrong, check that. For this question for hypokalemia, this one is okay. First question first. Sixth question, that one which I have given. Yeah, here. This one related to diabetic ketoacidosis and HHS, we can explain for 1 hour if we need.
Yeah. So that
Yeah,
is what I was thinking after this slide, no? So I'll just compare DK with HHS for them.
yeah. You compare DKA with the HHS, and also better we add some important lab investigate. Hoping I have updated that in the PDF if I'm not wrong. We
Yeah,
need
yeah.
to.
Of HHS you've updated. So I thought, no, एक
Hmm.
side, one side, one ಕಡೆ ನಮ್ DK ಬಗ್ಗೆ ಎಲ್ಲ ಮಾತಾಡ್ಬಿಟ್ಟು, the other side, I can just write HHS, whatever is there. So,
In the sense
both I'll just
differentiate.
compare.
You mean the to differentiate the aspects, right?
Yeah, yeah, correct. So just like, I've done it for the last question. See, like this.
Yes, 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 yes. You can do that for HHS and DK as well. Yeah,
Yeah.
hopingly I have missed that. Yeah.
Hmm.
I have kept the important investigative points, that is somewhat they go wrong with that particular aspect, even we say multiple times.
Yes, yes.
With
No, anyway,
DK,
you've given me half the question. So for me, the workload has come down,
yeah, but yeah, my contribution should always be there for internal
Thank you
medicine.
so much, Prajwal. ಯಾರಿಷ್ಟು ಯೋಚನೆ ಮಾಡಲ್ಲ. Thank you.
Yeah, internal medicine ಅಂದ್ರ ಮೇಲೆ ನಾವು ಬರಲೇಬೇಕಾಗ್ತದೆ. ಇಂಟರ್ನಲ್ ಮೆಡಿಸಿನ್ ಆಗಲಿ ಯಾವುದೇ ಸಬ್ಜೆಕ್ಟ್ ಆಗಲಿ ನಮ್ಮ ಪ್ಲಾಟ್ಫಾರ್ಮ್ ಅಂತ ಹೇಳಿದ್ರ ಮೇಲೆ ಐ ನೀಡ್ ಟು ಗೋ ಫಾರ್ ದಟ್.
Yeah, yeah.
I need
Thanks,
to
yeah.
have it. Yeah, I need to have an eye on each and every aspect, what the quality of questions they are doing, and see some of the things. What happens is directly they give the one-liners and they go with the fact-based questions. Like before 2018, we were having some entire different exam pattern. Like we
Correct,
can
correct.
see the direct questions it was happening. But here nowadays the exam patterns, they are entirely changing, and they need the skillful doctors. They don't want something like who mug up the aspects. Like
Correct,
that is
correct.
that was kept in mind, and I have prepared the questions that one as you see with that hepatitis B. Actually, you
Yes,
said
yes,
that,
yes.
yeah.
No, I just reframed that question. I
Hmm.
think I forgot to show you that. Yeah, so this was the one. This was the one. I've kept the same answer only.
Hmm.
So the question only I've reframed. Okay, an intern
And,
suffers a needle stick injury while treating an HBsAg positive patient. Which marker will indicate recent HBV infection in this patient?
okay. Answer remains the same. Yeah.
Answer remains the same. So
Yeah.
just a question matra ಹೇಗೆ form ಆಗಿದೆ, I've just changed that.
ಅಲ್ಲ ಇದು ಏನ್ ಗೊತ್ತಾ, ಪಾಪ ಕಿಡ್ಸಿಗೆ ಹೆಲ್ಪ್ ಮಾಡ್ತಾ ಇದೀರಿ ಅಷ್ಟೇ ನೀವು.
True that, true that.
ಪಾಪ.
ಮತ್ತೆ
But what
ಇನ್ನೊಂದು ಕೇಳ್ಬೇಕಾಗಿತ್ತು,
oh,
did you go through this new this is off the topic. There is one new academy that's come up, Cerebellum Academy anta. Did you see that?
yeah, Cerebellum Academy, it is something offline, I feel.
No, what they're doing, no, which I found very interesting is, they are doing this 90-second one MCQ thing, like shorts ತರ ಹಾಕಿ.
ಯಾ ಯಾ
So
ಯಾ
in
ಯಾ
that,
ಯಾ ಅದು ಏನ್
ha,
ಗೊತ್ತಾ, ಅದು ಪ್ಲಾನ್ ಆಗಿದೆ. ಏನು ಅಂತ ಹೇಳಿದ್ರೆ, ಫಸ್ಟ್ ಆಫ್ ಆಲ್ ಫ್ರಂಟ್ ಎಂಡಿಗೆ ಹೋಗುವಾಗ ಫ್ಯಾಕಲ್ಟೀಸ್ ನಾವು ಪ್ರಾಪರ್ ಮಾಡ್ಬೇಕಲ್ಲ ಫಸ್ಟ್.
correct, correct,
ಏನು
correct.
ಅಂದ್ರೆ ಅಲ್ಲಿ ಮಾಡುದಾದ್ರೆ ನಾವು ಮಲ್ಟಿಪಲ್ ಆಸ್ಪೆಕ್ಟ್ಸ್ ಕಾಂಪಿಟೇಟರ್ಸ್ ಚೆಕ್ ಮಾಡಿ ಮಾಡ್ಲಿಕ್ಕೆ ಆಗ್ತದೆ ನಮಗೆ. ಇಶ್ಯೂಸ್ ಏನಂದ್ರೆ ಈ OBS ಸಾಫ್ಟ್ವೇರ್ ಟೆಕ್ನಿಕಲ್ ಆಸ್ಪೆಕ್ಟ್ಸ್ ಎಲ್ಲ ನೋಡ್ಕೊಂಡು ಈಗ ಪ್ರೊಮೋ ವಿಡಿಯೋ ನೋಡಿ, ಪ್ರೊಮೋ ವಿಡಿಯೋ ನಾವು ಕೊಟ್ಟಿರುವಂತದ್ದು ಅದು ಫ್ಯಾಕಲ್ಟೀಸ್ ಹೇಗೆ ಕೊಡ್ತಾ ಇದಾರೆ ಚೆಕ್ ಮಾಡ್ಬೇಕಾಗುತ್ತೆ.
Correct. No,
ಆಮೇಲೆ
I was wondering, faculty ನಮ್ದು ಅಷ್ಟು well known ಇಲ್ಲ ಅಲ್ವಾ? So we have to be very, honest about that. We are not very well known people in the industry.
ಫ್ಯಾಕಲ್ಟೀಸ್ ಇದು ಹೇಳ್ತೇನೆ. ಪ್ರಾಬ್ಲಮ್ ಏನ್ ಗೊತ್ತಾ, ನ್ಯಾಷನಲ್ ಲೆವೆಲ್ ಫ್ಯಾಕಲ್ಟೀಸ್ ನಾವೇನು ಬೇರೆ ಪ್ಲಾಟ್ಫಾರ್ಮ್ ಅಲ್ಲಿ ನೋಡ್ತೀವಿ, ಅವ್ರನ್ನ ಅಡಾಪ್ಟ್ ಮಾಡ್ಕೊಂಡು ಕರ್ಕೊಂಡ್ ಬರೋದು ಬಾರಿ ದೊಡ್ಡ ವಿಷಯ ಅಲ್ಲ. ನಮಗೆ ಕರ್ಕೊಂಡ್ ಬಂದಾಗ ಏನಾಗ್ತದೆ ಅಂತ ಹೇಳಿದ್ರೆ, ದೇ ವಿಲ್ ನಾಟ್ ಸ್ಟಿಕ್ ಆನ್ ಎಂಟರ್ಲಿ ಹಿಯರ್. ಸಮ್ ಆಫ್ ದಮ್ ದೇ ವಿಲ್ ಸೇ ನಾಟ್ ಟು ಗಿವ್ ದ, ಲೈಕ್ ದೇ ವಿಲ್ ಆಲ್ಸೋ ಸೈನ್ ದ ಅಗ್ರಿಮೆಂಟ್ ವಿತ್ ಅದರ್ ಪ್ಲಾಟ್ಫಾರ್ಮ್ಸ್ ನ.
Correct. ಅದು ಇದೆ, plus they are very seasoned, no? So they will not be ready to adapt to changes very easily.
No. They will demand on their own and they will what do you think, ಏನಂತೀರಾ, ಮಾರ್ಕೆಟ್ ಅಲ್ಲಿ ನಿಮಗೆ ಡಿಮ್ಯಾಂಡ್ ಇದೆ ಬನ್ನಿ ಅಂತೆಲ್ಲ ತುಂಬಾ ನಾವು ಕೇಳಲಿಕ್ಕೆ ಹೋದಾಗ ಅವರು ಗೇಮ್ ಪ್ಲೇ ಮಾಡ್ಲಿಕ್ಕೆ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತಾರೆ ಹೆಚ್ಚಿನ.
True that. So what I wanted to ask was similar. Just think about it. 90-second shot instead of showing my face and ಬರೀ ನನ್ನ ಆವಾಜ್ ಇಟ್ಕೊಂಡು 90-second MCQ ಮಾಡ್ಬೋದಾ?
ನೋ ದಟ್ ಇಸ್ ನಾಟ್ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡಿಂಗ್. ಯಾಕೆ ಗೊತ್ತಾ ಪ್ಲಾಟ್ಫಾರ್ಮ್ ನಾವು ಅದನ್ನ ನೋಡೋದಕ್ಕಿಂತ ಅಲ್ಲಿ ಇಶ್ಯೂಸ್ ಏನಾಗ್ತದೆ ಅಂತ ಹೇಳಿದ್ರೆ,
tell me.
ಯಾವ ಫ್ಯಾಕಲ್ಟಿ ಟೀಚ್ ಮಾಡ್ತಿದ್ದಾರೆ ಅಂತ ಫ್ರಂಟ್ ಎಂಡ್ ಅಲ್ಲಿ ಕೇಳ್ತಾರೆ. ಈಗ ಏನಂತ ಹೇಳಿದ್ರೆ ಮ್ಯಾರೋ ಆಗಿರ್ಬೋದು, ಅನ್ ಅಕಾಡೆಮಿ ಆಗಿರ್ಬೋದು, ಅವರೆಲ್ಲ ಏನ್ ಮಾಡ್ತಾ ಇದಾರೆ ಅಂತ ನೋಡ್ತಾರೆ. ಯಾವ ಫ್ಯಾಕಲ್ಟಿ ಮುಖನೇ ಬರಲ್ಲ ಪ್ಲಾಟ್ಫಾರ್ಮ್ ಅಲ್ಲಿ, ಅದರಲ್ಲಿ ನೀವು ಪರ್ಚೇಸ್ ಮಾಡಿ ಏನ್ ಮಾಡ್ತೀರಾ ಅಂತ ಕಮೆಂಟ್ ಬರೋ ಚಾನ್ಸಸ್ ಇದೆ.
Okay, fine.
ಅಂಡ್ ಒನ್ ಮೋರ್ ಥಿಂಗ್ ಏನ್ ಗೊತ್ತಾ, ಅಲ್ಲಿ ಇಶ್ಯೂಸ್ ಇದರಲ್ಲಿ ಮಾರ್ಕೆಟ್ ಅಲ್ಲಿ ಫಸ್ಟ್ ಆಫ್ ಆಲ್ ವಾಟ್ ವಿ ಆರ್ ಲುಕಿಂಗ್ ಈಸ್ ಅವರ್ ಫ್ಯಾಕಲ್ಟೀಸ್ ಟು ಬಿ ವೆಲ್ having a very good grips with the subjects. First of all, if the faculties are having a very good grip with their subject, and it is not at all an issue to make a very much demand for faculties tomorrow. ಲೈಕ್ ದ ಗೇಮ್ ಏನ್ ಗೊತ್ತಾ, ಇಲ್ಲಿ ಫ್ಯಾಕಲ್ಟೀಸ್ ಗೆ ಟೀಚಿಂಗ್ ಬರ್ತದೆ, ಫ್ಯಾಕಲ್ಟೀಸ್ ಗೆ ಗ್ರಿಪ್ ಇದೆ ಸಬ್ಜೆಕ್ಟ್ ಮೇಲೆ ಅಂತ ಆದ್ರ ಮೇಲೆ ಇಟ್ ಈಸ್ ಆಲ್ ವೆಲ್ ಡಿಪೆಂಡಿಂಗ್ ಆನ್ ದ ಮಾರ್ಕೆಟಿಂಗ್ ಟೀಮ್ ಟು ಡೂ ದ ಫೇಮಸ್ ಆರ್ ಸಮಥಿಂಗ್ ಲೈಕ್ ದ ಡಿಮ್ಯಾಂಡ್. ಏನು ಗೊತ್ತಿಲ್ದವನು ನಮ್ಮ ಮಾರ್ಕೆಟಿಂಗ್ ಟೀಮ್ ಅವ್ರು ಹೇಗೆ ಗೊತ್ತಾ, ಇದು ಏನಂತ ಹೇಳಿದ್ರೆ ಫಸ್ಟ್ ಗೆ ಮ್ಯಾರೋ ಬರೋಕ್ಕಿಂತ ಮುಂಚೆ ಆಗಿರ್ಬೋದು, ಪ್ರಿಪ್ಲಾಡೆ ಬರೋಕ್ಕಿಂತ ಮುಂಚೆ ಆಗಿರ್ಬೋದು, ಏನ್ ನಡೀತಾ ಇತ್ತು ಅಂತ ಹೇಳಿದ್ರೆ ಎಲ್ಲ ಮಾರ್ಕೆಟಿಂಗ್ ಟೀಮ್ ಇದು ಗಿಮಿಕ್ಸ್ ಅಷ್ಟೇ. That's it. In an academy, if you see, there are worst faculties I can say.
Yeah.
To be frank, that is an, I don't want to say the name. To be frank, there are no superheroes as they of other faculties which they teach for other platforms. But what they are doing with the marketing. That's it.
Correct.
Like ಏನು ಅಂದ್ರೆ ಇಲ್ಲಿ ಫಸ್ಟ್ ಆಫ್ ಆಲ್ ಟಾಪ್ 25 ಟಾಪ್ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ MCQs ಅಂತ ಯಾಕೆ ಇಂಟ್ರೊಡ್ಯೂಸ್ ಆಯ್ತು ಅಂತ ಹೇಳಿದ್ರೆ, ಟು ಗಿವ್ an initiative to our particular product, and we are supposed to launch it in somehow. Like how we are launching is also important, and they will ask what kind of platform, whether do you have any kind of updates in your YouTube, whether you have updates in social media, etc. They will be asking. So we need to answer, like what happens, the competition is very much stiff in the market, and we need to have answers for each and everything.
So true.
Yeah,
don't worry. I think we'll crack the code, because ella dedicated agidare. So we'll crack the code,
Yeah, we can do that. She has lost.
Yeah. Tell me.
Yes. So even what happens, we are supposed to look for even those short subjects as well in the future. But what happens is the upcoming exam is so near, so that this initiative has been taken.
Okay, fine.
And what happens, we are having the deadlines to release this particular products, and hopefully Sagar knew that very well. Like we are even planning how to launch this particular product, like whether we are releasing each and every aspects of question bank, test series and videos at a time, or we are launching it by distributing. Like question bank will be ಹೇಗೆ ಅಂದ್ರೆ question bank ಅನ್ನು one time ರಿಲೀಸ್ ಮಾಡ್ತೇವೆ, ಟೆಸ್ಟ್ ಸೀರೀಸ್ ನ one time ರಿಲೀಸ್ ಮಾಡ್ತೀವಿ, ಆ ತರ ರಿಲೀಸ್ ಮಾಡ್ತೀವಿ ಹೇಗೆ ಅಂತ ಪ್ಲಾನ್ ಮಾಡಬೇಕು.
Okay.
Like everything we can't manage at a time. Like as it is a new platform to the market, they will not get used to that. Something we need to create demandful in the market first of all, so that is being promoted, and every works around this one what you call path.
Correct.
Yeah, for the next exam pattern ಗೆ for example ಏನಾಗ್ತದೆ ಅಂತ ಹೇಳಿದ್ರೆ, ನೀಟ್ ಪಿಚಿ ಹೋಗ್ತದೆ ಹೇಗೂ 2023 ಗೆ ಲಾಸ್ಟ್ ಆದ್ರೆ, ಇವರೆಲ್ಲ ಈಗ ಏನ್ ಮಾಡ್ತಾರೆ ಅಂತ ಹೇಳಿದ್ರೆ ನೆಕ್ಸ್ಟ್ ಎಕ್ಸಾಮ್ ಪ್ಯಾಟರ್ನ್ ಅನ್ನ ಹಿಡ್ಕೊಂಡು ಮಾರ್ಕೆಟಿಂಗ್ ಶುರು ಮಾಡ್ತಾರೆ. ನೆಕ್ಸ್ಟ್ ಆಗ ಒನ್ ಅಂಡ್ ದ ಸೇಮ್ ಆಗ್ಲಿಕ್ಕೆ ಸ್ಟಾರ್ಟ್ ಆಗ್ತದೆ. ಸ್ಟೂಡೆಂಟ್ಸ್ ವಿಲ್ ಸ್ಟಾರ್ಟ್ ಟು ಥಿಂಕ್ ವೆದರ್ ಟು ಗೋ ಫಾರ್ ದಟ್ ಪ್ಲಾಟ್ಫಾರ್ಮ್, ವೆದರ್ ಟು ಗೋ ಫಾರ್ ದಿಸ್ ಪ್ಲಾಟ್ಫಾರ್ಮ್.
True. Very
that is what we are targeting actually. So if you are very well known with the students, then please to recommend for them, and we'll be giving the high benefits for them. That is for sure.
I've told my, juniors from Surat, Pondicherry, Bangalore, everyone will join. So ನೋಡೋಣ Friday ಎಷ್ಟು ಜನ ಬರ್ತಾರೆ ಅಂತ.
Yes, yes, sure. ಏನು ಅಂತ ಹೇಳಿದ್ರೆ we are doing something not for this one, what do you call, just for the purpose of running the companies or something. We are something doing it for the dedicated purpose. Something it should be beneficial to the medical, this one, what do you call, juniors or something like that.
Yeah.
Yeah. So that please to recommend, and let us see what happens.
ಖಂಡಿತ ಇದು ನಮ್ಗೆ ಹೇಳೋದೇ ಬೇಡ ಅಲ್ಲ. This is now our, we are the part of a team ಅಲ್ವಾ. So
Yes, obviously.
yeah, ಅದಕ್ಕೆ. So ಸಾಗರ್ ಇದ್ದಾರಾ ಹೋಗ್ಬಿಟ್ಟಿದಾರಾ?
ಸಾಗರ್ ಇದ್ದಾರೆ ಅವ್ರಿಗೆ ಕನ್ನಡ ಬರೋದಿಲ್ಲ.
सागर आप है ना उधर?
Yeah, हाँ जी मैं.
Sagar, you haven't understood anything, right?
No.
तो कन्नड़ा सीख लीजिए सागर, जरूरत पड़ेगी आपको.
अच्छा.
जी. तो मुझे कहिए, अगर अभी मुझे स्टॉप करना है तो स्टॉप स्ट्रीमिंग करना पड़ेगा?
हाँ, वहाँ पे ऑप्शन आएगा मैम.
ये वाला?